Good afternoon, everyone. Good afternoon, everyone, and welcome to the CDPH and CMA Virtual Grand Rounds. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's session, which is entitled California Surgeon General, Strong Start and Beyond. Cardiovascular disease is the most common cause of death for all Californians, both men and women. But what I didn't know is that data shows that cardiovascular disease is the most common cause of death in new mothers from pregnancy until their first year postpartum. In this virtual Grand Rounds, we're very excited to hear from California Surgeon General Diana E. Ramos, MD, about a multi-stakeholder movement, Strong Start and Beyond, an initiative spearheaded by her office. The program's dedicated to reducing maternal morbidity and mortality, with particular emphasis on addressing disparities and a concentrated focus on cardiovascular disease across the lifespan. Next slide, please. Here are our speakers' disclosures. Next slide, please. And this is our agenda for today. Next slide, please. Just a reminder, this series is accredited for CME credit. Make sure you do your survey that's sent at the completion of the webinar so that we can send you out your certificates. Next slide, please. And now I would like to welcome back Dr. Erica Pan with her state epidemiology review.
Great. Good afternoon, everyone. Thanks so much. Sorry for my technical difficulties last time, and I will just launch into it. Let's go to the next slide. Let's go into the next one. So this afternoon, I'm going to try to cover on 3 topics. I'll try to cram a lot in, but you may have some interest in the current and recent H5N1 avian flu situation in California and beyond, a brief update on respiratory viruses, and we can talk more about that at future Grand Rounds as well as we plan for the winter, and then evolving Mpox concerns. Next slide. So first, again, I want to talk about H5N1 bird flu. And, as other kind of zoonotic diseases and other novel flu strains in the past, there are different kinds of influenza A and different hemagglutinin and neuraminidase, and they can spread across different species. And so you can see a lot of different ways and complexities of how this particular virus can spread across different species. Next slide. So just kind of giving you a brief overview as far as what has been happening over the last several years. Again, flu A viruses are important as we monitor these from the public health perspective and actually animal agriculture. So not only do they have pandemic potential, but there are animal disease outbreaks. So I already mentioned there are several hemagglutinin and neuraminidase subtypes. So in January of 2022 was our first detection of highly pathogenic avian influenza H5N1, which was a very specific clade. And that was the first time it was noted in the United States. And then soon after, it was detected in domestic poultry in the US. And then that summer, we first had our first detection in wild birds in California. There were also other mammal detections over time, beginning as early as 2022. And then we had our first detection in August of 2022 in domestic poultry in California. And again, the term highly pathogenic avian flu is really about the pathogenicity to poultry. So very high mortality in poultry, not necessarily when it's transmitted to other animals or other species, but there have been over 7 million birds affected with H5N1 in California alone since 2022, and over 100 million in the US. And sadly, when we've had these domestic poultry outbreaks, they've had to do large culling, and it's been pretty traumatic for the industry as well. And then this year in March, as you likely have heard, there was the first detection of this specific H5N1 avian flu detected in dairy cattle. And this was very unusual and somewhat concerning in those first dairy cattle herds in Texas. Next slide. Since then, it has spread from Texas, and there's a lot, I am learning a lot too about, there's a lot of inter-cattle transfer across different states. And so since that first detection, and that is thought to be that first introduction from a wild bird into dairy cattle, there have been over 197 herds positive in 14 states since March. We just recently confirmed positive 3 dairy herds in the Central Valley here in California just on August 30th. All of those herds have been placed under quarantine. We do anticipate there are likely future herd detections in that area, but the California Department of Food and Agriculture has similar authorities as we do on the human public health side and can place those herds under quarantine, start doing testing in the immediate area, and exposed employees are being monitored for symptoms. And that, of course, is what public health is the most concerned about at this point. There are no human cases of H5N1 that have been confirmed in California. It's also interesting, most infected dairy cattle fully recover. So they might have decreased feed intake, decreased milk production, and they definitely have some signs of illness, and they're very closely monitored as far as how much their heart rates and their training. They actually have these like cow Fitbits that they wear in these sophisticated dairy farms. And we also know, really important for all of you to know and to talk to your patients about, that pasteurization of milk continues to be demonstrated to inactivate the virus. So for pasteurized milk, this is not a concern, but certainly of concern for other spread. CDPH is also collaborating closely with our Department of Food and Ag and other state partners to monitor and assess these herds. So again, the supply of milk and dairy foods remains safe. There are actually 6 raw dairy farms in California that are getting random testing as well from our Department of Food and Ag. And so far, there have been no detections in any raw dairy farms in California. Next slide. So what about humans? So there have been 15 human detections in the US since 2022. 9 of those were poultry exposure, all in Colorado, 4 exposed to dairy cattle, first again in Texas and then in Michigan and Colorado as well. And just recently, just in the last several days, 1 with no known occupational exposure to sick or infected animals in Missouri. So that source of that infection is still under investigation. The symptoms in the US, thankfully, have been quite mild. They've been some conjunctivitis, some URI symptoms, maybe some fevers or mild temperature elevations. There was 1 with an underlying medical condition that was hospitalized, but in general, they've been largely quite mild. And there may be other kind of mild infections that haven't actually sought testing, and all of these, except this most recent one in Missouri, were dairy or poultry workers. So the overall assessment to humans in general remains quite low, but again, we are monitoring exposed workers and also really monitoring closely for any mutations, and that is what's great about whole genome sequencing, is to be able to follow these whole genome sequencing and looking for specific mutations. But there are no concerns in any of the identified strains in dairy cattle or humans for any changes that would make them more human to human transmissible, which is what we're monitoring for. Next slide. So how is spread occurring from infected cows or animals to people? So again, like many other things, it can be fomite, person to contaminated surface, like other fomite transmission, direct splashes. So you can imagine if there's raw cow milk, splashing into a person's eyes, or if they have unprotected other mucous membranes, that is another way to potentially be infected. And certainly eating or drinking raw milk or inhaling aerosols from raw milk. And then, of course, handling sick or dead barn cats. There have been several barn cats who have been quite ill with neurologic symptoms, or other animals infected with the virus. So those are sort of the ways that it could be transmitted. It's actually not as clear from these 14 cases for sure how transmission has occurred, but those are all likely sources or ways. Next slide. So for all of you, I think, really want to make sure, as you are looking at individuals who come to you with respiratory symptoms and or conjunctivitis, asking them if they happen to be, and especially those of you that practice in areas where there might be more agricultural workers, or if you know that your patient population has agricultural workers, to be asking them about potential animal exposures or occupations. If you're going to send specimens for flu testing, many clinical labs can do some subtyping to rule out seasonal flu. And here's some, really specific directions on how to do respiratory testing, which is like you would do any other NP swab for flu. It is now approved to do conjunctival swab testing, and then definitely, of course, lower respiratory tract if you have a seriously ill patient. And for severely ill people, we definitely would want to see multiple specimens from multiple sites. And we have detailed instructions on our health advisories that are posted and on our website. And again, the other important thing is, if you do suspect that you might have a patient with avian flu, and if they have that occupational or other animal exposure, not only to please send testing for flu A, but notify your local health department immediately. And especially if they're, depending on what your clinical lab can do, it can get routed or split to be tested at the public health lab. And either those public health labs, many of them across California, can do H5 testing, or we can send it to our state lab to do that, or another reference lab to do that. And the turnaround time has been quite quick on some of the specimens that have been tested to date. And again, no detections in humans in California to date. Next slide. So again, key messages are for you all is to test people who develop symptoms consistent with flu, again, including conjunctivitis, which is not often what we think of with conjunctivitis, if it's been within 10 days of exposure, and notify your local health department. And then for symptomatic persons with known exposure, we are actually recommending empiric flu antiviral treatment, but that is something you'd be working with your local health department with as well, as far as that empiric treatment. Next slide. So I'm going to move on to more general broader respiratory virus trends and our winter preparedness update very briefly. Next slide. So just to kind of show you, this is a really nice graphic of since actually the 22-23 season to now, what our different big three viruses have been doing. So you can see, of course, that 22-23 season, we definitely had a high hospitalization rate for COVID, which is the orange. And then last winter, it was a little bit lower. This recent sort of summer surge we've seen has been actually almost as high as our last winter, although I think our denominators are a little bit different as far as hospital reporting, which was no longer required after the end of last sort of, I think it was May that the requirements stopped. And as we all know as well, in general, our respiratory viruses tend to peak during the fall and winter months, but every single season since COVID has been with us, we've also seen summer upticks, and this summer was no different. Thankfully, as you can see here in that red circle, it is on the decline now, and our wastewater surveillance is mirroring those same trends. So now we're really, working to plan for the next winter surge of all of these viruses. While it still causes many hospitalizations, again, the outcomes, as you are all seeing anecdotally and in your patients, are becoming more similar to flu. Also really interesting to note, there's a recent JAMA report as well looking at leading causes of death, and COVID has now dropped to the 10th leading cause of death in the US in 2023 from third during the pandemic and fourth in 2022. And interesting, flu and pneumonia had been around 9th and have dropped down a bit. So it is, again, more similar to flu was in the past. So that gap is decreasing. Next slide. And then this is just a nice sort of all in one place chart to show you sort of the broad recommendations about COVID-19, flu, and RSV vaccine. I should have actually highlighted another more detailed slide too about maternal RSV vaccine for this audience with Dr. Ramos as your keynote speaker, but we have a lot of great resources, and one of the supplementary slides you'll see is for our immunization webinars that we have biweekly on Fridays as well, for a lot more details on timing and administration of these three viruses. But of course, one of the key prevention people can do now is get vaccinated in preparation as soon as available and when indicated. Next slide. So specifically, just briefly about COVID-19 vaccines, as you've likely heard as well, it has now been approved for the 24-25 season. Some of the questions we're definitely getting are about whether that strain is similar to what is circulating. And definitely the 24-25 mRNA contains KP.2 strains, which are very, very similar to the KP.3, which is circulating right now, and should have good cross protection, and definitely closer to the currently circulating strain than the 23-24 vaccine. Recommended, just like flu, for everyone 6 months of age and older. And just a reminder that it restores and enhances your protection against virus variants and reduces the risk of long COVID, COVID-19 associated hospitalizations and deaths. As far as kids over 5 years of age who recently received the 23-24 can get the current season dose 2 months after their last kids and adults, I should say. So anyone who got a vaccine over 2 months ago is eligible to get the new one. If you've been recently infected, you can consider waiting at least 3 months to receive this next 24-25 vaccine that is now available. So far, CDC is not currently recommending an additional dose like they did last year for those who are over 65 who are not moderately or severely immunocompromised. But again, data will be monitored in the upcoming season, and if any recommendations need to be updated, they will. Next slide. So as far as RSV vaccine recommendations, ACIP is recommending that older adults should receive a single dose of RSV vaccine. So especially those 75 years of age and older, those 60 to 74 years of age at increased risk of severe RSV disease, and people who have already received that vaccine last year are not necessarily recommended to receive another dose this season. So far, our data shows that there's some protection for at least 2 seasons. And the vaccine may be given year-round, but of course, consider giving it in the late summer and early fall to maximize the benefits of vaccination through 2 seasons. And I will maybe make sure we send out or put in the chat later also some detailed recommendations about maternal and infant vaccination as well. Next slide. So I wanted to shift gears, and some of the reason I didn't include as much about RSV vaccines and some of those details is because Mpox is, of course, something that has been in the media and some increasing concerns, and I can explain a little bit more why. Next slide. So you may have heard on August 14th that the World Health Organization declared Clade 1 Mpox outbreak in Africa a public health emergency of international concern. So this was right after the African CDC made a similar declaration. And since 2023, the reason they made this declaration was that almost 20,000 cases, including over 500 deaths, were reported in the Democratic Republic of Congo. And then soon after that, there were first Clade 1b cases to be diagnosed outside the African continent. So that was in Sweden and Thailand. And both of those cases had traveled to Africa. So this rapid rise of Clade 1b Mpox cases in the DRC and recent spread led to these declarations and is concerning for further spread across countries in Africa as well as outside the continent. Next slide. So why are we more concerned, or what's different? So there are actually different clades of Mpox virus, like many other viruses that have different clades and strains. So clade 1 and clade 2. So what you all have already been seeing since 2022 and what emerged then as a public health emergency then was clade 2b. And so that was the global outbreak that started. We are still seeing some transmission in California. Overall, in California, we've seen over 6,000 confirmed cases and thankfully only 3 deaths to date, and those typically in severely immunocompromised individuals. But clade 1 is what has been increasing more recently, and that has historically been confined and endemic in Central Africa, but it has been associated overall with increased transmissibility, more severe infections, and higher case fatality rates. And then within that clade, though, there are 2 distinct outbreaks and patterns that we're seeing. So clade 1a is the one that is still typically more through contact with infected wild animals, so zoonotic or household transmission, or during patient care without appropriate PPE. A large proportion of those cases have been in children and has a much higher case fatality rate than clade 1b. But actually, it's looking more and more like lower than previously reported, especially if people have access to healthcare and adequate supportive care. Supportive care is actually quite important. Clade 1b Mpox is a newer type that was first identified last fall, about a year ago. And this is also similar to Clade 2b that we've seen already in the US, is identified with sexual transmission, including not only men who have sex with men, but heterosexual transmission as well. But this case fatality rate is also much, much lower. So I think what we're most worried about spreading, next slide, is this clade 1b Mpox V with a lower case fatality rate. So again, this is just showing you visually, so the Democratic Republic of Congo is where these have been concentrated, but it has slowly been in Eastern Africa. This clade 1b has spread, and then more recently into Thailand and Sweden. So there is a risk of potentially seeing, more spread, I think, outside of Africa of this clade 1b, but again, it's a lower severity compared to what's still a huge problem in DRC. And next slide is what can people do about it? So the medical countermeasures that are used in our ongoing clade outbreak here include Mpox vaccine, the Jynneos vaccine, and antiviral medications. We still expect that TPOXX or ticagrelor are expected to be effective against clade 1 infection. There was one recent trial where it wasn't a huge difference in a small number, but the supportive care was also the most important thing there in supportive healthcare. And really what we want to do is make sure we get people vaccinated. Certainly here in California, we want to make sure men who have sex with men and people who are traveling to these countries who might be sexually active should be getting vaccinated. And we want to get a higher number of people who are potentially at risk for Mpox to get these 2 doses of vaccine, and should be, as you can see, up to 89% effective. There is finally some vaccine arriving in the DRC and Nigeria, so we are also hoping that that will really help to mitigate the outbreak there in DRC. Next slide. So we did send out a health advisory in mid-August, and we anticipate another one coming out soon from the CDC, really talking more again about travelers going to impacted countries to consider getting up to date on Jynneos vaccine as well, especially if they are at risk, if they are sexually active. And I believe that might be my next slide. Last slide, next. Yes, and just some huge acknowledgements and more detailed immunization updates at these upcoming webinars. Thank you very much, and I'll see you next time.
Great, thank you so much for the opportunity to be here.
Hi, Dr. Ramos, I'm so sorry, my internet is funky, but maybe you can hear my voice. Can you hear me clearly?
Yes, I can.
Okay, so before you get started, we're so grateful to have you here. I wanted to give you a quick introduction. You won't see my face. So Dr. Diana Ramos is a renowned public health leader and California's second Surgeon General and the first Latina Surgeon General. As California's doctor, she's the leading spokesperson on the most pressing public health issues of the time within the state of California, with a mission to advance health and well-being of all Californians. Dr. Ramos was raised in South Central Los Angeles and has provided reproductive care to thousands of Californians as an OBGYN at Southern California Kaiser Permanente over the past 3 decades. She also holds a Master's of Public Health and an MBA. Her leadership spans across many organizations. She lectures, she writes, and I highly recommend reviewing her full bio online, but I want you to hear directly from her. So Dr. Ramos, we're so grateful to have you here today.
Thank you so much. My pleasure. It's my honor to share with you Strong Start and Beyond. And this is going to be an initiative that is really going to put California above and beyond maternal mortality and morbidity. Remember this day, because you can say, oh yes, I remember when we first heard about Strong Start and Beyond. And if I can get the next slide, please. No disclosures, and the next one. And these are the things that we're going to go over. What is Strong Start and Beyond? Look at the disparities of perinatal outcomes, and then what can all of us do as healthcare providers? And I know some of you may be thinking, I'm not an OBGYN, I don't see reproductive age people, I'm a pediatrician, or I'm a family practice doc. Hopefully by the time that we're done, you'll realize, well, maybe there's something that I can do or I can say to help make a difference in this big initiative. So I want to start by framing the work with a video that has been created by our office. So if we can have the next slide and start the video. Thank you.
His family is mourning a great loss while also celebrating the birth of a new baby. 19-year-old Ariana Sanchez died due to complications while giving birth to her daughters. The father, Ezekiel Esparza, says he still remembers the day he and Ariana found out that they were going to be parents.
But she was telling me, she was like, the line's not going away, babe. The line's not going away. She's the love of my life.
The idea that in one of the wealthiest countries in the world, the United States America, we have the highest rates of maternal mortality. That Black women in our country in this era are 3 times more likely to die in connection with childbirth. I think it's inexcusable.
Once known as the world's fastest woman, Bowie died at her Florida home from complications of childbirth. The tragedy is resonating deeply with Black women who are at higher risk of dying while pregnant.
The circle of life begins with the birth of a child, and that journey begins with pregnancy. People who are pregnant or who have had a baby know their bodies and know when something does not feel right. When they speak, we must listen.
Thank you. So you had a sneak peek as to why for Strong Start and Beyond, but really what oftentimes resonates with providers, with scientists, is the data, is the numbers, and because each number sadly represents one life. And thankfully, as much as we speak about maternal mortality, it is an overall rare event. But we can't help but hearing something coming up in the news. It feels like almost every other day about maternal death. And we have heard that the U.S. has third world rates of maternal mortality. And you can see the trends, the top trends, the dark blue line, the line on top is the U.S. rate. And the line below that, the pink line, is the California rate. So California has the lowest maternal mortality rate in the country. So we have done an amazing job. And you can see the rates that have from 2013 to now 2021. You can see the maternal mortality rates. From 2019 to 2021, you can see that there was a spike, a big spike in maternal deaths, not only in the U.S., but you can see the California deaths as well. And the calculation on 2021 would be the estimate 12.6 per 100,000 deaths if we excluded COVID. But sadly, you can see that COVID really impacted maternal deaths nationwide and in California. About 25% of all maternal deaths in the country increased as a result of COVID. So we have all been traumatized. Again, one death is one death too many, and each of these statistics represents one person. I was on a webinar earlier today and heard the statistic that for every one death, there is a minimum of 135 lives that are impacted from that person's life. So it really isn't just one person. It is 135 plus. It's a family. It's a community. Can we have the next slide, please? So, one before. Okay. So in California, and I want you to stay focused on California because you hear a lot of data that is national, but in California, there was a 45% increase, 45% pregnancy-related deaths in 2020, and that was as a result of COVID, 45%. In 2020, 24% of the pregnancy-related deaths were from COVID-19, and in 2021, 71% of the pregnancy-related deaths were from COVID-19. So this is unacceptable. We've heard that the disproportionate number of people who were impacted by COVID were oftentimes those who did not have access to vaccines, those who were essential workers, those who could not get the immunizations and to get the care that they needed. So this is a call to action in terms of realizing that we have a lot of work to do to make up for the harm really that was caused by COVID-19 with our moms. Can I have the next slide, please? So what about the deaths by race and ethnicity? And this is so critically important to realize. So you see in blue is the trend. From 2013 to 2015, the highest number of deaths were in the Black moms. As time went on down to 2019 to 2021, you can see that the maternal deaths decreased. Not quite yet, but that's okay. The maternal deaths decreased maybe just a little bit, but not much. So from 49.1 per 100,000 to 49.7. But the number that I want you to now look at is from 2013 to 2015. The Hispanics are in the pink bar. The death rate was 8 per 100,000. And then from 2019 to 2021, now you can click, the maternal death rate went to 17.7 per 100,000. The maternal death rate doubled. Let's just stop and think. It doubled. It increased for the Hispanic population. We've done a good job. We have a lot more to do to decrease the Black maternal mortality rate, but we can't lose sight of the fact that we have a doubling of the maternal deaths in the Hispanic population. If you look at the Asian population, it increased slightly from 2013, 2015 from 12.2 to 14.5, 14.4 for the latest data. And for the white population, also increased slightly from 10.2 to 11.3 to the most recent data, 14.0 per 100,000. So yes, we are on our way to improving the maternal mortality death rate for the Black population, but we have to really keep an eye on all moms because we're failing moms. If the maternal mortality rate has doubled and it has increased slightly for all of the other populations. Next slide. So in the U.S., the most common cause of death varies by ethnicity. In the Black population, the most common cause of death is cardiovascular. In the Hispanic, it is infection, and primarily at the time it was COVID because this is 2020 data. In the Asian, it was emboli, and in the white population, it was mental health conditions. So varying causes depending upon your ethnicity. Can I have the next slide? But in California, this is very different. The most common cause of death for all ethnicities in California, whether you're Black, Hispanic, Asian, white, is heart disease. So this is, we have to stop and think, wow, heart disease, not only is it the #1 killer of men and women nationwide overall, but it is the most common killer of our moms here in California. So heart disease really plays a big role in everyone's health throughout their entire lifespan, because we know that heart disease doesn't start and stop with one instant. It really is a lifestyle of behaviors that have left and made us get to whatever that high risk behavior is for heart disease. The #2 cause of death is hemorrhage, and behavioral health is 12%. I do have to say that behavioral health, when we looked at some other data, it was actually the #2 cause of death. But typically in California, up until recently, focusing on suicide as well as substance abuse has not been looked at as a whole. I know there's efforts that are going forward to look at that. And this week, just to make you aware, is Suicide Awareness Week. So behavioral health is a critically important piece in overall maternal death. And then the other is infection. But if you look at the proportion, I mean, it's almost, double from 23% to 12%, which are the second leading cause, the third and fourth leading causes of death. Next slide. And The one thing that we have to realize that in California, the preliminary estimates now are that 89% of the maternal deaths are preventable. And I do have to say that's preliminary, but we know that it as at least 80%. So if we can prevent 80% plus deaths, we really need to come together and address the most common causes of maternal death. And you see what they are here in California. The one that really reaches all of us, impacts all of us, no matter what your medical specialty, is heart disease. Next slide. In terms of the timing of death, 62% of the death occurred after the first day of delivery. And the time frame is up to 1 year postpartum that we look at. Now, this is critically important because this means that the new mom is out in the community already. So oftentimes they may be having physical symptoms or mental health issues, and sadly, they're not getting the help that they need. But it's when perhaps the baby is taken to that well child visit that a pediatrician or a family practice physician looks at the mom and the baby and asks, does a quick PHQ-9 Edinburgh questionnaire on the mom, that we start to pick up, well, maybe there's some depression there. The baby's failing to thrive. Yes, part of it could be a physical finding, but part of it could be that the mom is just not, because she is depressed, is not able to care for that baby. Or it could be that there's high blood pressure in the mom, and there's headaches, there's other symptoms that are happening. And again, all of that is interfering with the care of the newborn. Really important. Let's just keep it in mind when you see patients, and especially if you're in pediatrics or in family practice, and you see that the person that you're caring for is a relatively new mom delivered within the past 12 months, ask simple questions. How are you feeling? How are you feeling mentally? And high blood pressure. Did you have high blood pressure? And if you see that they may feel comfortable with you, if you're even engaging and you're building up rapport, is there a headache? And so it may be time you need to see your primary care doctor because I'm caring for your child. But it's a simple question that we can all do when we're caring for our patients. Doesn't mean that you're going to take the responsibility to care for them. It means that you're just asking a question and getting the help that they may be needing. Next slide. The reality is that 1 in 3 reproductive age women have at least one chronic condition. So again, going back to the fact that oftentimes it's not the health of the pregnancy that is impacting the outcomes at the current time. It's the health that they had before they were pregnant. And you can see here the list of all of the other medical conditions that are oftentimes seen in reproductive age people. And then most importantly, those preconception conditions impact pregnancy and then the postpartum, because we know that really a woman's pregnancy, a person's pregnancy, is a window to the rest of their health. Next slide. And contraception options, really important because of the fact that on average, half of the births are unplanned. So if you have 1 in 3 people that have a chronic condition and they are not using any contraception and they happen to become pregnant, you know, oftentimes people say, wow, I wish I would have known that my high blood pressure was going to impact my pregnancy, or that the medication that I'm taking could be teratogenic and now I'm pregnant. So just having a conversation, and you may not feel comfortable writing for contraception, but you can do the 2 key questions, and that is, are you sexually active? And are you planning to become pregnant? this year? And if they say yes, perfect. Make sure that you're taking folic acid, and it's great that they're there to see you for the well exam. But if they say no, then it's the opportunity for you to say, well, you may want to get some counseling or consider using a contraceptive method, because what your medical condition or the medication that you're taking could cause problems if you become pregnant. So the contraception conversation is also a critical piece in helping people plan and have the healthiest pregnancy that they potentially could have. Next slide. And one of the other areas that my office covers is ACEs, the Adverse Childhood Experiences. And we can't overlook the fact that it really is the health of the mom when she is pregnant that is really going to be impacting the health of that child. So whether there's abuse, neglect, or mental health conditions, other household conditions that increase the stress, such as racism, such as intimate partner violence, all of the stress on the mom really does impact the health of the child. It causes dysregulation in that child and future developmental issues in that child along all of their healthcare pathway. Next slide. So again, just recapping the types of ACEs that there are. It could be abuse, neglect, and the household challenges. But really, now we have to realize if we help mom be the healthiest they can be, then when the child is born, then they could be the best parent they can be. Because oftentimes there's if you're not taking care of yourself, if you're neglecting yourself, you're not eating, you're not sleeping, all of that impacts your ability to care for that newborn, especially in the beginning when there's a lot of sleepless nights, trying to get the feedings down, all of this compounds. So again, by helping the parent, by helping the mom, we're really helping not only the newborn, we're helping the whole family and that person's future health. Next slide. And I can't, whenever I speak to physicians, I cannot overlook the opportunity to remind folks that we are human too, and that mental health impacts us as well. And the fact that there is help for all of us. Again, this is Suicide Awareness Week, and roughly one doctor dies by suicide every day. That's 365 physicians that we lose nationally. And women are 3 times more likely to die by suicide. The most 60% of people who commit suicide are successful the first time. So really critically important, we need to watch out for each other. We have the highest suicide rate of any profession, and 29% of practicing physicians reported depression, at a rate that's twice that of the U.S. adults. And on the left is a screenshot of a group that was formed to help support physicians, because sometimes we think that we're alone and that the mental health issues, we can't talk about it. But I know CMA has a lot of wonderful resources, and I encourage you, if you don't feel comfortable speaking to anyone at your job, reach out to CMA, reach out to your family, and let's get healthy so that we can then help our patients. Next slide. And finally, Strong Start and Beyond. We're going to be launching the blueprint on a week from today, next week in San Francisco. And we're going to announce big, audacious goals on how and what are some of the pieces to achieve. But the most important big things that we're going to do is we're going to educate and empower individuals on their reproductive health. What are the choices that you have to make sure that you are the healthiest you can be, and reduce maternal mortality. The QR code provides a link for you to be able to sign up and to be part of the initiative. Again, reducing maternal mortality, really it's improving the health of not just moms, improving the health of society as well. Next slide. And I mentioned earlier, pregnancy is a window to future health. It's a stress test for what's going to happen, because we know that high blood pressure during pregnancy has a 63% increased risk of future cardiovascular disease. So for those of you who take care of middle-aged menopausal patients, you can ask them, did you have preeclampsia when you were pregnant? I mean, that may even be a quick question that we may ask patients. Diabetes, 20 to 50% will develop type 2 diabetes later in life. So if parents know that they're diabetic, they're going to be higher risk for diabetes, that may be a priority in their well exams to ensure that they have the proper weight, the proper diet. The same thing for the high blood pressure. And depression overall, if there's depression in pregnancy, there's an increased risk for suicide. So overall, 1 in 5 people have some type of depressive disorder during pregnancy. Next slide. Next slide. Thank you very much for your attention and the opportunity to share Strong Start and Beyond.
Thank you so much, Dr. Ramos. I realize that I don't know how I'm supposed to be addressing you, so I don't know if it's Surgeon General Ramos. We're pretty casual around here, so you tell me, but we're really grateful to have you here. And we have a really excited audience. I see you're getting some hand claps from some of the audience members, and have a few questions for you, and we'll have some for Erica too if she's still around. I'll say my internet is acting up today, so if I disappear, then our team will carry on with the questions. Dr. Ramos, you have an army of folks on this call who are actually quite eager about this and wondering, what can we do at the local level to assist with this campaign?
At the local level, be on the lookout for a lot more opportunities to participate. The QR code that we had shown on one of the slides is one of the easiest ways to sign up and participate. But I have to say that you are all doing exactly what you need to do, and that is caring for patients. So keep on doing what you're doing, and I can't ask for more. Strong Start and Beyond is going to be focusing on community, on the population, empowering, educating what high risks are, what questions to ask the providers. We always say, doctors have to do X, Y, Z. I think you are all doing it already. What we have to do is empower our patients to be able to care for themselves when they leave our offices, because we know that 80% of healthcare happens outside of the offices, outside of the healthcare settings. So please just continue doing what you're doing, and you will hear a lot more information, a lot more requests. There's going to be, about every 2 months, there's going to be something that is going to be released that is going to be really focusing on the Strong Start and Beyond, and reminding folks that we're all working towards the big audacious goal that's going to be announced September 17th.
Wonderful. Well, the suspense is killing me, but I'll have to wait. Erica, I'll give a question to you. You talked about what one should do if you've recently had COVID, perhaps wait 3 months at least to get the vaccine. We have a participant who says, what about a 60-year-old immunocompromised adult who had RSV? They're wondering how long might they have protection? And in general, how long do we wait after RSV to get the RSV vaccine?
Sure. Yeah. Thanks for the question. And while I have the floor, just wanted to thank Dr. Ramos as well for her incredible work, such important work for our state. So RSV vaccine is thought to actually last for 2 years. I bet we'd probably have to get back to someone about the sort of if they're severely immunocompromised, if there are any different recommendations about that. I actually don't know off the top of my head, but in general, it's actually supposed to last 2 seasons, which is a bit unusual, I know, and yet another thing to track with this new tool in our toolbox as far as RSV vaccines for those that are most vulnerable.
Great, helpful. Dr. Ramos, just a general question for you. I think many of us are wondering about this really exciting role that you've been given in our state. So a couple of people asked, can you tell us what you do as Surgeon General, other than this important campaign that you've introduced us to today?
So I'm the voice of what we are doing at the state level, sharing the work that we're doing, but the priorities and ACEs, as well as now Strong Start and Beyond, are going to be some of those major priorities. Sharing also with a lot of stakeholders what California is doing. We are doing so much amazing work here at the state that national partners look to see and ask, what is it that we are doing, and just elevating the great work that all of our, healthcare teams and the investments that have been made for California's health.
Wonderful. Well, again, thank you for that work. You mentioned that this is important information for even those of us like me who are pediatricians and parents of young girls in this room. And so one of our participants did ask, what is being done as part of this campaign right now, if anything, to kind of educate younger people, teens, et cetera, in their preconception years, or younger women, to help them understand how to stay healthy early, because really prevention is key to many of those causes that you described.
One of the things that we are going to be releasing within the next few months is a tool, a resource that people can actually answer that question for themselves. And the analogy I like to use is it's like a Cosmo quiz. And back in my day, you had the Cosmo magazine and you answered 5-6 questions and you look to see, is my relationship going to work? Well, we're doing that, but for health. If you were to become pregnant right now, what would be the risk status, or what would be the potential outcome of your pregnancy, so that you can start to look and find the information for yourself. So the vision of that is to make that quiz available, and it is not going to be in the health setting. It is in the community, and this is what I said. So we are really targeting the community. So we've already had commitment from major app companies that they're going to put that little widget on their app so that folks can know and start to question and seek more information so that they can make the informed decisions. There are so many amazing programs already out there. We are not hoping to create any new programs. We are hoping to really elevate the amazing work that is being done at the local level by the public health departments, by the nonprofit organizations, and just bringing that awareness to the community so that the healthcare teams can then say, oh yeah, I heard that the March of Dimes has this program available for you for free, or WIC has this program. So really, it's just cross-collaborating all of the work that's already out there and elevating the resources that we have already in California.
Great. And that local focus is super important. And so another of our participants had asked if there's any specific parts of this program that are trying to reach a very difficult to reach population, the vulnerable people who are unhoused, young women, pregnant people who are unhoused.
Our aim is to reach all of the population. And so if there are programs that folks know about, please let our office know, because again, we are not looking to create any new program. I know there are programs locally that are focusing on pregnant unhoused people, to be able to partner and to provide the resources for information so that the folks can then help themselves going forward. please let us know. That's where we need that cross collaboration and that information.
Wonderful. Erica, I'm going to have to apologize if you had this slide, but I was out of the internet when you said it. But did you go over today? Someone was asking about the current wastewater levels of COVID, how widespread it looks like it is right now in the moment.
I didn't show the slide because I was already worried about how much time I was taking, but I can basically say verbally that it's, and I'm just trying to pull it up because I had it as a supplementary, but yeah, the wastewater is also decreasing now, and it's been still correlating pretty well with our other kind of data as far as test positivity. We have less quality data as far as hospitalizations, but we still follow test positivity, deaths, and then the wastewater. So yes, those trends are decreasing, and of course a little bit of geographic variability.
Okay, great. Thanks. Back to you, Surgeon General, Dr. Ramos. There's a sense that many rural counties in our state have quite a shortage of cardiology and maternal health facilities. And this participant was just wondering if there's something that at the state level is being done to really try to address this, also as another way to help with maternal mortality.
So I can't give you specifics on what is being done, but I can tell you that there are ongoing efforts to improve access to referrals. And I know CalAIM is coming up with some amazing work already to help improve that. The telehealth referral services, and that now with technology, we're able to get the referral information, a consult virtually. So the rural issue is not just an issue here in California. I'm on some national rural work groups that really it is a national need, and sometimes we think we're unique, but this is something that on a national level solutions are coming up and being developed. But here in California, I know that CalAIM is looking for innovative ways to address some of those needs.
Great. And I think we have time for one final question, Erica. Is there a role for flu vaccination in avian flu and H5N1?
It's a great question. So right now we don't think there's any cross protection between the seasonal flu vaccine and avian flu. And we are still definitely prioritizing outreach. So all of you, if you could also really, even more than usual, encourage your sort of agricultural worker patients to get seasonal flu vaccination. And there is a good candidate vaccine that the federal government has made that is a match for the current circulating avian flu strain. They've only been able to do about, I think it's around 5 million doses of the avian flu vaccine that they've not deployed. But I think if this escalated as far as human disease or impact, that would potentially happen. They were really trying to balance that seasonal flu production. How much could they produce without compromising our general seasonal flu vaccine production? But it's a great question, and I think we really want to encourage farm workers to get seasonal flu vaccine, not only for the basic sort of protection, but to help prevent any, and protecting them from seasonal flu, but also from any potential mixing, amongst sort of, one of our concerns, of course, is if you have two different strains in one species at the same time, that could then mix and cause a novel influenza strain.
Okay. Great. Well, unfortunately, that's all the time we have today for questions. I could talk to you both all day, but I really want to thank you, Surgeon General Ramos and Dr. Pan, as always, for presenting today's content. It's always super exciting, and I can't wait to hear more about this new program. Just a reminder to everyone, you will receive a survey today at 5 p.m. Please attest your attendance, and that way you'll get CMA credit. We'll send them out within a week. And I also wanted to mention that we have a really important election coming out with a proposition that is very important to our ability to take care of the more than 15 million Medi-Cal recipients in California. Prop 35, we strongly advocate a yes vote on that and are happy to answer any questions from CMA on what that implies. And I really look forward to seeing you next month on Tuesday, October 8th. We're going to address the really important question of how to provide care for youth at risk of suicide. But these techniques will also help us address the issues that Dr. Ramos talked about of not only our loved ones, but our colleagues who are also at high risk of suicide. So please join us then, and thank you all for your time.